Our next speaker is Dr. John Felix, an infectious disease pharmacist, intern at Stanley Medical College and Hospital. And last but not the least, he's the founder and CEO of our Medodrix, and he's here to provide us insights on antimicrobial essentials that all must know before going into the main sessions. Over to you, Dr. John Felix.
Hello everyone, am I audible?
Yeah, you're audible.
Yeah. So first of all, I would like to welcome you all to the Medodrix-Conference on Infectious Disease Pharmacy. So our theme for this year's conference is World Infectious Disease Pharmacist Day, Join the Fight, Pharmacists Engaging Communities in Antimicrobial Stewardship. So thank you all for being here and for the dedication to this vital cause. We have an exciting and informative program lined up filled with insightful presentations, engaging discussions and opportunities for meaningful collaboration. Let's join forces and continue to make a significant impact in the fight against infectious diseases. So I'll be continuing with the second introductory session. The first part mainly focused on the microorganisms. The second part is focused on antimicrobial essentials. So why do we need a basics on microorganisms and antimicrobial agents? You know, we have 5 sessions in MD-CIDP conference. The speakers will be focusing mainly on the microorganisms and antibiotics, especially these antimicrobial agents. So it's important to know the basics on these microorganisms and these antimicrobial agents. Actually, antimicrobial agents cannot be covered within a 30 minutes of time. So I'll be focusing more on the antibiotics and a bit on antifungals and antivirals. So what are antimicrobial agents? Antimicrobial agents are the medications which are used to treat or prevent infections caused by microorganisms like bacteria, virus, fungi, and parasites. So the drugs that are used to treat bacterial infections are called as antibiotics, and drugs that are used to treat viral infections are called as antivirals, and drugs that are used to treat fungal infections are called as antifungals, and drugs used to treat parasitic infections like malaria are called as antiparasitic drugs. Next slide. Antibiotics are the medicines that help stop infection caused by bacteria. They do this by killing the bacteria or preventing its growth or replication. The pharmacology behind antibiotics is that it mainly acts by 2 mechanisms. One, they may inhibit the cell wall synthesis, and the other one, they may alter the cellular functions. The classification of antimicrobial agents, as I said earlier, antimicrobial agents like antibiotics act by 2 different in vitro effects. That is, it may kill the bacteria or it may prevent further growth or replication process. So based on this, we will classify as bactericidal and bacteriostatic drugs. Bactericidal means it will kill the bacteria, and bacteriostatic means it will prevent further replication or further growth of the bacteria. The drugs that exhibit bacteriostatic effects include tigecycline, tetracyclines, clindamycin, macrolide antibiotics, linezolid, and sulfonamides. And the drugs that exhibit bactericidal effects may include aminoglycoside, beta-lactam antibiotics like penicillin, cephalosporins, carbapenems, fluoroquinolone antibiotics, and glycopeptides like vancomycin, ticoplanin, and daptomycin, metronidazole. So it's an important thing. Based on the mechanism of action, the drugs are classified as cell wall inhibitors, protein synthesis inhibitors, DNA synthesis inhibitors, and RNA synthesis inhibitors. These are the major mechanism of action that an antibiotic exhibits. So the drugs that exhibit cell wall synthesis inhibitors are beta-lactam antibiotics like penicillin, cephalosporin, carbapenems, and glycopeptide antibiotics, phosphonic antibiotics. And then we have protein synthesis inhibitors, example tetracyclines, tigecycline, aminoglycosides, macrolide antibiotics, clindamycin, linezolid, and chloramphenicol. DNA synthesis inhibitors effect is given by fluoroquinolone drugs, and RNA synthesis inhibitors are rifamycin class of antibiotics, which may include rifaximin and rifamycin. First, we will focus on cell wall inhibitors antibiotics. As I said earlier, beta-lactam antibiotics are the main drugs in this class. The mechanism of action for all the beta-lactam antibiotics like penicillin, cephalosporin, and carbapenem are same. The only difference will be the binding site of each antibiotics. So beta-lactam antibiotics, first they bind to the penicillin binding protein and they inhibit the cross-linking of peptidoglycan. And peptidoglycan is something that makes a cell wall rigid. When this peptidoglycan cross-linking is inhibited, the cell wall deficient bacteria is formed, which will undergo lysis and bactericidal effects occurs. The adverse effects with beta-lactam antibiotics are hypersensitivity reactions, diarrhea, and penicillins, most particularly methicillin, can cause acute interstitial nephritis, and some penicillins can trigger seizure in high-risk patients, and hematologic toxicities. Cephalosporins commonly cause diarrhea, eosinophil count above normal range, and thrombocytopenia. And serious effects may include Stevens-Johnson syndrome and C. difficile colitis and hemolytic anemia. The classification of penicillins: the natural penicillin is penicillin G, and semi-synthetic penicillin we have acid-resistant alternative to penicillin G, that is penicillin V, which is more commonly used for rheumatic heart disease. And then we have penicillinase-resistant penicillins like methicillin, cloxacillin, dicloxacillin, and extended spectrum penicillins, which covers large number of microorganisms like aminopenicillins like ampicillin, amoxicillin, uridopenicillins like piperazillin, and carboxypenicillins like carbenicillin. And beta-lactamase inhibitors is not a part of penicillins actually. Some bacteria can produce an enzyme called beta-lactamase enzyme, which can destroy or can cause resistant bacteria to that antibiotic. So beta-lactamase inhibitors are usually combined with these penicillins or cephalosporins to prevent such destruction of the antibiotic. For example, we have piperacillin, tazobactam, cefoperazone, sulbactam, amoxicillin, clavulanic acid. Next slide. So cephalosporins, it has a similar mechanism of action. The only thing we need to remember is the first generation covered mostly gram-positive organism, and the further came generations covered gram-negative organisms as well. And the fifth generation, we have ceftarolin, which covered methicillin-resistant Staphylococcus aureus also. And we have carbapenems, which has a code word medic, where M stands for meropenem, E stands for ertapenem, D stands for doripenem, I stands for imipenem cilastatin. These are effective against space M organisms. You can see the full form of space M here: Serratia, Pseudomonas aeruginosa, Acinetobacter, Citrobacter, Enterobacter, and Morganella. And it is ineffective against spam organisms like Stenotrophomonas, Pseudomonas, atypical organisms like Legionella chlamydiae, and MRSA. Then we have glycopeptide antibiotic like vancomycin, teicoplanin. As I have said earlier, glycopeptide antibiotic will have a same mechanism of action like penicillin. The only difference is the binding site. See, vancomycin binds to the acyl D-ala moieties of NAM, NAG peptides. NAM means N-acetylmuramic acid, and NAG means N-acetyl glycosamine peptides. So this will prevent the incorporation of NAM, NAG peptides into the peptidoglycan matrix, and thus the same mechanism of action continues. And then we have spectrum of activity. Vancomycin teicoplanin covers most gram-positive organisms, and it only covers anaerobic organisms as well. Then we have adverse effects. Vancomycin, one of the important effects to be considered is it can cause Redman syndrome when it is given as an fast IV infusion. And vancomycin can also cause hypokalemia, abdominal pain, diarrhea, nausea, vomiting, and sometimes it can cause ototoxicity, nephrotoxicity, and Stevens-Johnson syndrome. Teicoplanin can also cause ototoxicity and nephrotoxicity. Next one, please. Next, we have phosphonic antibiotics. So you can remember like this, phospho. So phosphomycin. Phosphonic antibiotics, it has a similar mechanism of action like our penicillin. The only difference is the binding site here. It binds covalently to the cysteine condensation of phosphoenol pyruvate, and then it prevents the production of peptidoglycan here. So there will phosphomycin has an important additional effect, like phosphomycin can prevent the adhesion of organism in the epithelial cells. For example, we have epithelial cells in our urinary tract as well as respiratory tract. So phosphomycin can prevent the adhesion of the bacteria in the epithelial cells, and it is most commonly used for such infections. It covers gram-positive as well as gram-negative organisms. Clinically, it is used more for gram-negative organisms. Next. Then we have tetracycline and glycylcycline. Till phosphomycin, we have seen drugs that inhibit the cell wall synthesis. Now we are moving on to the next session, that is protein synthesis inhibitors. Tetracycline and glycylcyclines like tigecycline, they reversibly bind to the 30S ribosomal subunit. We have 30S and 50S ribosomal subunit. So we should remember this. The drugs can act on either of the subunit. So tetracyclines, it focuses on the 30S ribosomal subunit, and they prevent the binding of tRNA to mRNA complex, thereby inhibiting the protein synthesis. So the common adverse effect associated with tetracycline is tooth discoloration. So it is not recommended for children, and serious effects may include phototoxicity, acidosis, azotemia, serum blood urea nitrogen rise. Next slide, please. Then we have aminoglycoside antibiotics. So the classification is based on the usage, that is systemic or topical. The systemic aminoglycosides may include amikacin, gentamicin, streptomycin, tobramycin, etc. And the topical aminoglycosides may include neomycin. They have a similar mechanism of action like tetracyclines. They also bind to the 30S ribosomal subunit. And the only difference is tetracyclines and tigecycline can give bacteriostatic effect, whereas aminoglycosides can give an bactericidal effect. And aminoglycosides is it covers only the gram-negative organisms. It is sometimes given or combined with beta-lactam antibiotics to give an synergistic effect. The common adverse effects are dizziness, muscle weakness, spasm, headache, nausea, vomiting, and the serious effects may include ototoxicity and nephrotoxicity. Next slide. Then we have macrolide antibiotic, which are commonly used nowadays: azithromycin, erythromycin, clarithromycin. They are useful in treating respiratory tract infections, skin and soft tissue infections, sexually transmitted infections, Helicobacter pylori infections, and atypical mycobacterial infections. So the difference is macrolide antibiotic will bind to the 50S ribosomal subunit, and it inhibits a translocation step of protein synthesis. Generally, they are considered to be bacteriostatic, and some point or at a higher doses, it can exhibit bactericidal effect as well. And the common effects associated with it are abdominal pain, diarrhea, nausea, vomiting, increased liver enzymes, headache, prolonged QT interval. Next slide. Then we have lincosamide antibiotics. Lincosamide antibiotics, the most common example we know are clindamycin. It has a similar mechanism of action, like it binds to the 50S ribosomal subunit and prevents protein synthesis. So clindamycin is bacteriostatic. The common adverse effects associated with it are drug eruption, abdominal pain, diarrhea, nausea. Serious effects may include Stevens-Johnson syndrome, Clostridium difficile infections, jaundice, and acute kidney injury. The spectrum of activity, it covers only the gram-positive organisms, and it covers only the gram-negative anaerobes. It will not cover gram-negative bacilli or cocci. Next one. Then we have oxazolidinediones. Oxazolidinediones, the common examples are linezolid, which is most commonly used for soft tissue infections. It also binds to the 50S ribosomal subunit and prevents protein synthesis. It has adverse effects like diarrhea, nausea, vomiting, headache. Serious effects may include hyponatremia and syndrome of inappropriate diuretic hormone secretion. Therefore, it can also cause lactic acidosis as an effect. Then Clostridium difficile infections, peripheral neuropathy, and seizure. It covers only the gram-positive organisms. Next. Then fluoroquinolone antibiotics. The only thing we need to remember is cephalosporins covered gram-positive organisms at first, and the further came generations covered gram-negative organisms. Fluoroquinolones act vice versa, whereas the first generation covered gram-negative organisms, and the further generations covered gram-positive organisms and anaerobes, atypical bacteria as well. Mechanism of action, it exhibit antimicrobial effect on the DNA gyrase. We call it as bacterial topoisomerase 2 and bacterial topoisomerase 4. When it acts on the topoisomerase 2, that is, when it inhibits a DNA gyrase, it results in the relaxation of the supercoiling of DNA. When the DNA supercoiling is relaxed, the DNA strand breaks, and further the replication process is stopped. And then we have inhibition of topoisomerase 4, which impacts chromosomal stabilization during cell division, thus interfering with the separation of newly replicated DNA. Next. We have the spectrum coverage here. It covers gram-positive cocci, gram-negative bacilli, and it mainly acts against most of the gram-negative rods and atypical organisms as well. it is a drug of choice. Like ciprofloxacin and levofloxacin is a drug of choice for UTIs, and moxifloxacin is used in anaerobic infections. And then we have resistant respiratory tract infections is treated with levofloxacin and moxifloxacin, and gastrointestinal tract infections are treated with ciprofloxacin. Next. And the last one is rifamycin. Rifamycin is a RNA synthesis inhibitor. Rifamycin acts by binding to the beta subunit of the DNA-dependent ribonucleic acid polymerase enzyme. Okay, so when this binding blocks the translocation, and which will stop the transcription process. Transcription is nothing but the formation of RNA from DNA. When this enzyme is inhibited, the transcription process is stopped and RNA cannot be formed. The serious effects may include agranulocytosis, disseminated intravascular coagulation, hepatotoxicity, nephrotoxicity, anaphylactic reactions, and very rarely it can cause interstitial lung disease, which I have not seen clinically. This is an important chart, spectrum of activity chart. Like in the left corner, we have the names of the antibiotics, and then we have the gram-positive cocci names at the top, gram-negative bacilli, gram-negative cocci, anaerobes, and atypicals. So when we see a drug, let's see the first gen cephalosporins here. This covered MSSA, streptococci, E. coli, Proteus mirabilis, Klebsiella. And whereas the fourth gen cephalosporin covered MSSA, streptococci, and it covered all the gram-negative as well as gram-negative bacilli as well as cocci. And in this way, you can refer this chart for treating a patient and selecting an appropriate antibiotic for an organism. Next slide. So nowadays, it's very common that everyone gets an antibiotic. Even if it is a viral infection or bacterial infection, everyone gets an antibiotic. If this was a case, very sure the antibiotic resistance will occur, which will very surely can cause very big impact in the healthcare society, where the organisms will not be treated or cannot be treated with any of the antibiotics now we have. So now we are moving on to the antiviral agents. I have a very limited time now. I will finish it faster. Antiviral agents, virus consists of nucleic acid. It consists of either DNA or RNA, as we have seen earlier. So I'm not interested to cover this now. Next slide. So this is a common mechanism how the virus gets replicated. Virus enters the host cell, the protein coat gets opened. Now the viral particles like RNA, DNA gets out of the protein coat, and this will undergo several processes like transcription, translation, and then new viral particles are formed, and which will then the new protein coats are formed, and new viral particles get released from the cells. The common antiviral drugs, just remember DNA polymerase inhibitors, reverse transcriptase inhibitors, protease inhibitors. These are the common three classes of antiviral drugs. Then others, we have integrase inhibitors and fusion inhibitors. Next slide. So this is an overall chart. Let's start with this fusion inhibitors. So where when the fusion of the viral particle occurs, the RNA gets out of the viral particle and it gets into the host cell. And now, when this RNA is converted to DNA using the reverse transcriptase enzyme, and then the DNA need to be integrated with the host cell DNA. So this reverse transcriptase enzyme can be inhibited by reverse transcriptase inhibitors drugs like acyclovir, and then we have integration. Integration is inhibited by integrase inhibitors drugs, and it undergoes several gene expression and virus assembly, and the budding of new viral particles occurs. And during the budding of new viral particle, there is an enzyme called protease, which will help to form the protein coat and several enzymes responsible for replication of the virus. So when we inhibit the protease, the replication can be inhibited. Next. So the first one is DNA polymerase. It's a mechanism of action involves inhibiting viral DNA polymerase enzyme, which is crucial for virus replication. Drugs like acyclovir, vidarabine, these are nucleoside analog. These colorful sticks are called as nucleosides like adenine, guanine, cytosine, thymine. So these are the nucleosides, and our drugs like acyclovir and vidarabine has a nucleoside analog. So these are first proactive drugs which are inactive at first, and once they enter the infected cell, they undergo phosphorylation and converted into vidarabine triphosphate or acyclovir triphosphate. This active form competes with the natural nucleoside, and they incorporate with the growing viral DNA and exhibit viral elongation. So when this DNA polymerase enzyme is inhibited, then this process can be stopped and the viral replication can be halted. Next slide. The similar thing, we have a reverse transcription. As I said earlier, reverse transcription is a formation of DNA from RNA. So it needs an enzyme called reverse transcriptase. The drugs act by the same mechanism as I said earlier. It competes with the natural nucleotide and binds with the reverse transcriptase enzyme and inhibits its elongation process, and the viral replication process can be halted. Next slide. Then we have protease inhibitors. As I have said earlier, the virus needs a precursor to cleave the individual proteins, like structural proteins and functional proteins. Structural proteins example is protein envelope, and the functional proteins example like reverse transcriptase, as I have said earlier. So when we inhibit the protease enzyme, the cleaving of polyproteins precursor will be inhibited, and thus the polyprotein will not undergo cleaving, and there will be no production of structural proteins and functional proteins. Thus, the maturation of viral particles will be halted. Next slide. Then we have other classes of antivirals like integrase inhibitor and fusion inhibitor. So integrase inhibitor, as I've said in the first slide, whereas the viral DNA need to be integrated with the host DNA for replication. So when this integration step is inhibited, the viral replication cannot be continued. And then we have fusion inhibitors. The fusion needs to be taken like the viral cell will have a glycoprotein 120, where the fusion inhibitors will inhibit the binding of glycoprotein 120 with the host cell, and which will stop the entering of viral particles into the host cell. Now we are moving on to the antifungal agents. Antifungal agents, the only thing we need to remember is ergosterol, which is fungal cell wall. And the ergosterol is usually made up of squalene, which is converted to lanosterol by squalene epoxide enzyme, and then the lanosterol is converted to ergosterol by 14-alpha demethylase enzyme. Allylamines act on this cycle, whereas squalene is converted to lanosterol by squalene epoxidase. Allylamines inhibits this squalene in epoxidase, and thus it will inhibit the production of ergosterol. So the example of allylamine is terbinafine. Then we have azole antifungals, which will inhibit the 14-alpha demethylase enzyme. Thus, lanosterol will not be converted to ergosterol, and the cell membrane cannot be formed. The example of azole antifungals are ketoconazole. Then we have antimetabolite like flucytosine. So these are protein synthesis inhibitors. Like we seen in antibiotics, flucytosine is a protein synthesis inhibitor. So which will be converted to flucytosine 5-fluorouracil and act on the fungal RNA and inhibits the protein synthesis. And then we have polyene antifungals. The example is amphotericin B. The main mechanism is to increase the permeability of the cell wall. Obviously, it will result in cell death, right? So polyene antibiotics like amphotericin B will bind to the ergosterol and increases the membrane permeability to proteins and monovalent and divalent cations, and which will ultimately lead to cell death. So thank you all for your time. Thank you.
Thank you, Dr. John Felix. That was such an informative session from you. And I'm sure that this session would have given an idea to the participants on how antibiotics work and how to detect them and how to choose the correct antibiotic for any infection.